Okay, from current.
Basically, we learned that you're going to fail us all.
Yeah. I'm glad we got that recorded. So, yeah, the moral of the story is don't put restrictors on it. Where I grew up, I'm from hillbilly Central Illinois, and I was always told, there are only certain things you can do. So when I first got out of high school, I didn't bother with college. I went straight into working in a factory. And then I worked my way up through a factory, and I was actually running $1 million laser within a year working in that factory. And I just got so bored working there. I said, I've got to be able to do more than this. And so I did everything. I've been a sous chef. I've been a massage therapist. I worked in that factory with the lasers. I've done everything that I could possibly think of. And what's funny is that it doesn't matter how many things I did and how many things I did well. When I first started at DMU and I told my mom I got into DMU and how proud I was, and she goes, "Why?" Wow. Love my mom, but yeah, she's like, "Why? You can do anything you want. Why do you want to go to medical school? Who cares?" And it's just, that's kind of the attitude. If you put limiters, that was what kept me from going to college pretty much right after high school. So don't put limitations on what you can do. Never put limitations on what you can do. All right, so these steps. What do you want to know? STAR. Yeah, you got to know them. When we talk about respiration, this is kind of the overview of this whole system. So the first thing you want to get familiar with here is the terminology. When we talk about exchange of air between the external environment, that means everything outside of your body, in your nose, in your pharynx, in your larynx, and in your lungs. So everything that's outside, external to your body. I'm not talking completely external, but external to your blood, your tissue, blah, blah, blah. So you want to get exchange from out here down into the lungs completely. The second thing is exchange between the lung tissue, or like the airway in the lungs, into the tissue of the lungs. So getting across that membrane, and I'm not using technical terms for a reason so far. External is still outside the lungs. Then moving it internally into your blood is the second step. These two terms, ventilation and perfusion. Ventilation is moving air. Profusion is moving, profusion. It's also perfusion. It's moving blood. So when you perfuse tissues, it means you're pushing blood into the tissues. So profusion is the same thing. So ventilation is moving air. Perfusion or profusion is moving blood. Can you move air when you're dead? Can I move air in your lungs when you're dead? Yeah, I can keep jumping up and down in your chest, pushing air out and pulling air in. I'm ventilating you. Does it help you? No, because you have no blood flow. You have no perfusion. If you're dead, I'm not moving anything. Your blood's clotted. There's nothing going on. All I'm doing is moving the air that's outside of you. And then number 3, once you get that oxygen, those carbon dioxide exchange, whatever, when you get that exchange done, that oxygenated blood's going to move down all the way through the arteries. Is there exchange in the arteries? Nope. How about in the arterioles? Nope. Not until you get down to the what beds? The capillaries. So this oxygen and carbon dioxide are moved through the system, and then when they get down to the tissues, like the muscle, the organs, then they're exchanged again through the systemic capillaries. So here's the big picture. Here's the first step, bringing air into the lungs. That's, remember, external environment. Then there's exchange. What are the name of the little tiny structures that form the lung walls? Alveoli. So you get exchange across the alveoli into the blood, bless you. Step 3 is moving it through the system. Is there any exchange during step 3? Nope. This is arteries, arterioles, venules, veins. There's no exchange. Step 4 is when you get to the tissue, the target tissue, then you have exchange across that tissue capillary bed. So this is external respiration. Once you get inside the cell, then you have something called internal respiration. Internal respiration is the process of using the mitochondria and turning that oxygen into what? Oops. God, I keep forgetting. I caught that last semester. ATP, not HTP. Oh, crap. Look at this one here. What's wrong with this?
H2O.
It's supposed to be H2O. Yeah.
Whoa, is that the book?
Yeah. It's right out of the book. That's why they make the big bucks, and we're just here to edit them. Okay, so that's the first major thing. The second thing is, as I'm going into the systems, if you've noticed, there's a functions section, usually the first couple slides. Here are the main functions of the lungs. What do you automatically want to think of for lungs? Gas exchange. But that's not it. In fact, on the last section, I talked about something else you do with the lungs. When you breathe in, you expand the thoracic cavity. The lungs expand, compressing your vena cava. So what else does it do? It helps you pump blood. Yeah. So there you have. Enhances venous return. Bless you. Right. Helps you lose water when you breathe outside in the cold. You can see that water vapor leaving. You lose CO2, you lose water. Contributes to the maintenance of acid and base. Every time you see CO2, you want to associate with what? I told you this once before. Acids. So acid in general, right. So if you accumulate CO2 in your blood, acids accumulate in your blood. If you blow out CO2, what do you do to the acid in your blood? You lower it because it left, right?
I'm sorry, did you say carbon dioxide gets rid of acid?
When you blow out CO2, you lose acid at the same time. And number 4, helps you with singing, speech, vocalization by blowing the air across the vocal cords. Number 5, defend against inhaled foreign material. I love the way, I'll show you this anatomy-wise. Seems like no anatomy teachers ever really talk about this, but the way that your lungs are built, there's a reason that you don't have your nose on your nipples. There's a reason it's up here, and I'll show you. Because it's the bacteria and the debris that you breathe in. If you had holes going directly into your lungs, what happens to that air? It's not filtered, it's not clean, it's not purified. The reason we have a nose up here that goes all over the place is to help purify and get rid of debris and stuff. And number 6, it modifies the air. When you're breathing right now, this air out here, even though it feels quote-unquote humid, compared to the air in your lungs, it's not. If you brought dry air into your lungs, what would happen to those little tiny fragile alveoli? They'd dry out and they would start cracking. Yeah. It's just like in the wintertime, when it's really dry outside, what happens to your skin? It gets really dry, right? Because the dry air is sucking the water right out of your skin. Well, if you're breathing in that dry air, it's going to suck the water right out of your blood.
Why would breathing out be a respiratory? Why would that be a non-respiratory function? Wouldn't it be a respiratory function?
Why would breathing out be a non-respiratory function? I don't understand that question.
Well, because you say like when you breathe out CO2, you would get rid of acid. Wouldn't that be part of...
The acid part's pH. It's still... These are all respiratory functions. When you blow out the CO2, you're blowing out acids at the same time, which is number 3. It's helping regulate pH.
And then like the water lasts for heat elimination. Like when you're breathing out and you can see your breath, it's still respiratory, isn't it?
It's a non-respiratory, it's non-gas exchange function. Okay. It's still breathing. Okay. It's just not gas exchange. Does that make more sense? So these are all the non-gas exchange things that the respiratory system does.
Okay.
So when you look at the respiratory, we're talking like respiration, where this is saying respiratory system versus respiration, basically.
Okay. Sorry.
No problem. No, I'd rather have you ask than get confused later. Okay, then this is the branching. The anatomy, again, I'm not going to spend a ton of time, but look at the pathway. So here you're going from your trachea and you're splitting into the bronchi. Every time you divide, imagine if you're a little tiny particle of bacteria. You don't have, this bacteria in the air can't control where it goes. It just follows the flow of air. So it's going, if it's heavy, when this fork in the road hits, what's it going to do? It hits the wall. And then when it hits the wall, then it can be processed by your immune system. If it's light, the lighter ones will go and go off to branches. But what might it do? Hit that wall, or that wall, or that wall, or that wall, or that wall. So it's like a maze weaving back and forth. As that light bacteria comes weaving through, it's more likely to hit these branches. That's why large bacteria usually don't cause respiratory infections. It's the little ones like TB that actually cause respiratory infections, or viruses that cause most of the respiratory infections. Why? Because they're so small. Yeah, they can get way down deep into your lungs. Yeah, Mycobacterium tuberculosis is a really small bacteria. It's teeny tiny. So it just blows all over in your lungs. It doesn't get caught very well. Okay, and then there are the lungs pictures. They're zooming in on the alveoli. And the alveoli are like little grape bunches. What's cool about the alveoli is that even though they look like grapes, they're actually connected, one grape to another, by these things called pores of cone. So this one connects to that one through this little pore here on the side. That one will connect to the one behind it by the pore. So that when air comes in, it not only just comes into that alveoli, it circulates through and between the alveoli and then blows back out. So that way you get nice even distribution. When one alveoli expands, all the ones around it expand equally at the same time. They expand as a group so that you don't just have one that blows up. They all go. And then here are your capillary beds. You can see every alveoli surrounded by the pulmonary capillaries. So that gives it a lot of surface area. What's the benefit? Lots of surface area means lots of diffusion. Increased surface area, increased rate of diffusion. And then here you have the bronchioles. Bronchioles are the airway equivalent of what blood vessel? Arteriole. The characteristics, and I love talking about these back to back because a lot of the characteristics are carried over. Bronchioles are the what vessels? Resistance vessels, because they're surrounded with what? Smooth muscle. The bronchioles are the resistant airway because they're surrounded with same thing, smooth muscle. So their structures are very similar. Alveoli are simple squamous cells. Capillary are simple same squamous cells. What benefit do both of those features have? Surface area. Large surface area, but what about the distance to diffusion? Short distance, so it does what to diffusion? Increases diffusion. So the properties are consistent. Guess what happens if I take this airway and I shrink its radius? What do I do to its resistance? I increase the resistance. What happens to its flow? Decreases it. So these principles you already know, right? You've already learned them, you force them into your head, and you understand them. So anything that I do to this, if I shrink it down, you know the flow is going to decrease with it. If I open it up, what happens to the resistance? Decreases because the radius went up, so flow increases. What disease would cause these smooth muscles to constrict down, reducing airflow? Asthma. Right, and then this picture, I really need to fix it, but here you have the blood vessel, one simple squamous. Here you have the alveoli, one simple squamous. So the shortest diffusion, super, super short. Two flat cells with a little basement membrane in between. Quick diffusion. Oxygen goes out. I'm sorry, I shouldn't say out. It goes into the blood, and then CO2 goes out into the lungs. Quick. What do you think moves it? Pumps? Transporters? Passive diffusion. Little, tiny, non-polarized particles can move anywhere they want, and they move by passive diffusion. You have to know these cells, type 1 cells, type 2, and macrophages. They call them alveolar macrophages, by the way, because they stay in the alveoli. They get into the alveoli and they hang out there. They're always there. Type 1 make the wall of the alveoli. So you see all these type 1s, like my hands cupping around. A type 1 would be this hand, a type 1 would be that hand. They form the walls of the alveoli. Type 2 make something called surfactant. S-U-R-F-A-C-T-A-N-T. Surf, S-U-R-F, and then act, A-C-T, and then ant, as in the little bug, surfactant. Surfactant's whole purpose is to reduce surface tension. What's that do to diffusion? Increase diffusion. Oh, I skipped over macrophage. What's it do? Macrophage. Eats things. Yep, so if the bacteria gets down in there, then it can be eaten. I was just talking about tuberculosis. So the Mycobacterium tuberculi, what's interesting about that is it gets down here in the alveoli, and then it's even sneakier because it gets inside of the macrophage, and the macrophage can't eat it. It doesn't go through by being eaten by the macrophage. It actually sneaks in the back door of the macrophage and hangs out inside of it. So it's almost like if this is a military tank, it's like the invader getting in the tank and driving around. That's what TB does. Nasty little thing. And that's why once you've had TB, why do they want to test you for it years later? Because it could still be hanging out in those tanks, right? And if you've had TB in the past, there's no guarantee that you don't have the TB in you. It just means that you're good at isolating it off now, but you can still do what with it? Spread it. Yeah.
So when you get tested for TB, like for the school, what happens if you have it? Then
Yeah, I don't know.
I mean,
Maybe they just do it to make you nervous. I'm sure it limits.
that 3 times.
I'm sure it limits who. Yeah, it limits who you can work with too.
Can they like deny you from healthcare industry? Should they really?
I think like immunocompromised or working in a intensive care unit, I think that they would limit you. Or for even being able to work in anywhere, they may make you wear a mask at all times.
So you just basically.
Okay, so I gotta test people all the time in the hospital.
Oh my God! Did you hear that? Everybody move away from her.
How do you, as long as it's not active, it doesn't matter.
Yeah.
No, but like when you treat it, like I had to go through therapy or something to treat it. How do you kill it?
It's a bacteria, so antibiotics can treat it, but it's really evasive. And the worst thing about TB, like I said, is it hides in macrophages.
Yeah.
And number 2 is your body is actually not trying to attack the TB. The TB releases a toxin, and it's almost like a chaff that distracts your immune system. It's like throwing the stuff out that way, and then the TB runs the other way, so that your immune system goes that way, and the TB hides over here. So it's extremely evasive. It's really hard to attack. And because it still hangs out in the macrophage, you could have it years after you had your situation and still have it.
Dead space is coming along.
Oh, you do? So, yeah.
Dead space is how you get
How you get rid of the dead space? You don't. Once it's there, like a lot of times they'll get granulomas, which means your immune system can't kill it, so they just build this wall around it and say, that's where the bad stuff is, nobody go in there. And that you can't get rid of either. Yeah, most of the damage you do to the lungs is irreversible. So once it happens, like emphysema, when they destroyed that tissue, it doesn't come back. Not to scare you.
I mean, I already gave it to people, so I'm fine with it.
Well, as long as you're fine with it, how they feel. Okay, surfactants made in which cell? Type 2, what's its function? Decrease surface tension. And we're going to talk about surface tension a lot more in detail later. But surface tension, if you don't have much of it, your lungs don't expand. Or I'm sorry, if you have extreme surface tension, your lungs don't expand. I jumped ahead when I was trying to flip the switch. So if you have really high surface tension, it makes your lungs want to collapse. Like babies, when they're first born, they don't have a lot of the surfactant. So what do you know they have high risk for? Lung collapse, right? We'll talk about that too. Okay, so lungs, they occupy most of the thoracic cavity, of course. There's the lungs, there's the heart. What's the other little gland that sits in front of the heart? Starts with the T. Thymus, yeah, for the immune system. And then when you look at, you have all these branching airways, you have the alveoli, which, by the way, anytime you see lungs in the books, a lot of times they use the word lung and alveoli interchangeably, like groups of alveoli. Because when you look at the lungs, the bulk of the stuff you see is actually alveoli. Big bundles of alveoli. And then the pulmonary vasculature, the blood vessels going through. And here's a trick about the lungs, is there's no skeletal muscle inside of it. But what kind of muscle controls your breathing?
Diaphragm.
Which is what type of muscle?
Skeletal.
Skeletal. There's no skeletal in the lungs, but it still controls your breathing. And I'll show you how that works later.
So is there any muscle in your lungs?
Yep, there's smooth muscle in there. The only muscle in there is smooth. And the smooth muscle is just wrapped around the arterioles and the bronchioles.
Yeah.
And you already know about the arterioles, so it's controlling blood flow into the lungs. If you have low oxygen in your body, what do you think is going to happen to those arterioles? They're going to open up.
So is that when people with asthma, when they start breathing a lot of oxygen, they close?
No.
No,
That's
what
because, yeah, that's because of chemicals. All right, pleural sac. This is just a sac that goes around the lungs, just like the pericardial sac went around the heart. It's like a water balloon. When we talked about that before, you have this water balloon, you push the lung down in it, and the sac just wraps around. There's no breaks in it. Do you remember what we called the layer of the pericardial sac that touched the heart? Visceral. Yep. What do we call the side not touching the lung or the heart? The parietal. Same two terms. So you've got a visceral layer that touches the lung. You have a parietal layer that touches what? It's not the lung. It touches surface of the cavity, right? So it touches like the rib cage. And then the pleural cavity is the part on the inside. So pleurisy is when you have an inflammation in there. Makes breathing a little bit more difficult. And they say it sounds like two pieces, when you breathe, if you listen with a stethoscope, it sounds like two pieces of leather rubbing against each other. They say the same thing about when you have pericarditis, inflammation of the pericardial sac. It sounds like two pieces of leather if you're listening to the stethoscope. So how can you tell the difference? How can you tell if they have pleuritis, or pleurisy, versus pericarditis, if they both sound exactly the same? Tell them stop breathing. Exactly. If they stop breathing, you still hear it. What is it? It's the heart. Yeah. So they have pericarditis. So, yeah, next time you go to one of those Harley bars and you hear the leather chaps rubbing against each other, that's what it sounds like. My uncle just got back. He went somewhere. I was going to say it was Sturgis, but was Sturgis just the last month?
No.
Okay, then it was somewhere down in Florida, somewhere that he goes. And it's funny because he has those leather chaps, and I always think about that. But again, no breaks. It's like a water balloon. What would happen if you put something through this wall? Bad news. Yeah, it's going to lose it. It's going to collapse. And we're going to talk about why your lungs collapse in when that happens. So it causes a collapsed lung. All right, respiratory mechanisms, got to know them. 3 of them. There are 3 areas of pressure you're going to have to be familiar with. One's atmospheric pressure, which is all the air around you, wherever you're at, whether you're in Colorado or you're down here at sea level. It's the atmospheric pressure, and typically it's going to be 760 mm, capital H, little g, millimeters of mercury.
What was that?
760, like that. The second one is the intra-alveolar. Where's that at? Within the alveoli. So if you look at one alveoli, it's the air pressure inside that alveoli. And the third one is the intrapleural pressure. Where's that? The pleural cavity. It's that fluid in the pleural cavity. And I forgot to point that out, but it's fluid. It's a water inside the pleural cavity. No air in that pleural cavity. It's all water. So if you were to look back here,
Fluid pressure?
it's the pressure of the fluid in there.
Pressure out.
Yeah. So if we look at this cavity here, that's the pleural cavity. It's filled with water. It has a pressure. The inside of the lung has a pressure, and the outside atmospheric air has a pressure. Breathing manipulates those 3 pressures. Okay. So those are the 3 major pressures. A lot of times when you see the pictures referring to the lungs, you'll actually see one alveoli, because when something happens to one alveoli in a healthy person, the same thing happens to all the alveoli in a healthy person. So when you expand your right lung, you expand your left lung equally. They both expand, they both collapse at the same time. All those alveoli are working in unison. So when I draw a picture like this, there's the alveoli, there's the intra-alveolar pressure, here's the air outside, so the atmospheric pressure, and then there's that pleural pressure. And if you notice, the pleural pressure always stays below these 2 pressures. The pleural pressure doesn't ever want to match the atmospheric or the intra-alveolar. It always wants to stay lower. And that's important because it actually creates a pressure gradient. It creates a suction. So it's always sucking on the wall out here connecting to your rib cage, but it's always sucking on the alveolar wall too. So it's kind of holding them both together. So if I punctured this wall, that pressure equilibrates out with the outside. What happens? This is going to collapse. These 2 walls start peeling away from each other. So you never want to pop that balloon. When they talk about millimeters of mercury, this is what happens. They put this in a vacuum. This is a little puddle of mercury. It's liquid at room temperature. Without a vacuum, there's no air pressure. There's no air at all pushing on this mercury. And they take a tube and they put it down in it. And then suddenly they expose this chamber to air. The air comes pushing in, forces down on the mercury, and squeezes it up the tube. Guess how far up the tube the average air pressure pushes it up?
760.
Yep, 760 millimeters. And that's why they call it 760 millimeters of pressure. So what would happen to this pressure if you went up into Colorado where there's less air particles pushing on that? It goes down. Yeah, the air pressure or atmospheric pressure drops. What would happen if you went way down underwater and it's squeezing down on this? It goes up even higher pressure. It compresses that mercury and pushes up the tube higher. Right? So moving those pressures is how we're going to move air. I'm debating, we have 2 minutes left, that's where we're going to have to stop. So we're going to stop right there. And then we're going to talk about some of this in lab and then work on it tomorrow too. Can everybody see the folders? I forgot to open them up. Okay. So everything's there and the due dates are on there. So there are 2 homeworks for blood and they're not due until next week. It's actually blood and blood vessels and they're due next Thursday or Friday or something. Which, how do I get out of this?